Welcome everyone to the Lyme Disease Resource Center educational series. Today we have Dr. Robert Fox, who's been in practice in the Capital Region area since 1986. He's a graduate of Rensselaer Polytechnic Institute and SUNY College of Optometry. Dr. Fox has also completed a residency in Rehabilitative Optometry at the Northport VA Medical Center on Long Island. Dr. Fox is a fellow of the College of Optometrists in Vision Development. Welcome, Dr. Fox, and thank you so much for joining us today.
Thank you for having me, Maria. Am I good to go?
You're good to go.
You have the floor. Okay. Well, thank you for arranging this. This is such an important topic, especially if you live in the Northeast. When I first moved up here, it was sort of rare and far between. And it's amazing how many patients with tick-borne ailments I've seen now, of every type of size and shape. And so it's a topic that's near and dear to me. I had a vision therapist who was suffering from a case of long Lyme, and she had so many physical issues. She went from being a super healthy, competitive athlete to really suffering a wide array of symptoms and issues. She always put up a tough exterior, but she was really working hard just to get through the day many times. So I give her so much credit for doing as much as she did. And she ended up going back to school, and now she's a full-fledged occupational therapist, working mostly with pediatrics, but we still see her all the time. So we're going to talk about Lyme and mainly the neurovisual consequences of Lyme. We're going to learn about the unique services that neuro-optometry offers. We're going to hopefully understand by the end the visual processing deficits caused by Lyme and ways to signs and symptoms of these visual problems. And just going to spend some time at the end to help people become aware of what kind of optometric tools and treatments we have. I just got back from my big annual meeting, and we're all seeing so many patients with neurological issues now. We used to be the College of Optometrists in Vision Development, and this past year we changed our name to the Optometric Vision Development and Rehabilitation Association, just because the neurology world, medical world has found us and has learned that we have a lot of unique services that help a lot of these patients that have neurologically related vision problems. So we got a lot to cover. I'll give you as much as I can in the time allotted. What is neuro-optometry? Well, we understand that most of the vision process takes place in the brain, not in the eye. Most people think they've gotten an eye exam if they go to the motor vehicle or take their kid to the nurse or pediatrician and read an eye chart, and then you're done. That's really, again, that's just visual acuity. That's one of about 21 or so different visual skills. And we'll touch on these as we go along. But vision takes place largely in the brain. Even a lot of the most people's eye examinations are eyeball, eye health related, where you get checked for your prescription, maybe you get some eye drops and get dilated. They look in at the back of the eye, and then they're kind of done. And it's almost like my exam first begins at the back of the eye and works its way into the brain. 20/20 does not mean perfect vision. 20/20 means you could see letters that are about a half-inch high at a distance of 20 feet, one eye at a time. Doesn't have anything to do with how your eyes aim, move, focus, or work together. We understand that vision is a learned process, just like you learn to walk and talk as an infant and toddler. when you're born with very basic visual and limited visual abilities, and you learn how to direct your eyes and learn how to use your eyes to direct movement and action. Vision is motor. In fact, the retina is the only part of the retina is brain tissue, which means the eyeball, the back of the eye, the retina is the only part of the brain that actually moves. And I think that's pretty cool. In addition, 20% of the visual nerve fibers go to parts of the brain besides the visual cortex. Mainly they go to parts of the brain involved with balance, movement, posture. So again, when you see a lot of these neuro-based vision problems, a lot of the chief complaints are dizziness, vertigo, balance problems, very, very common. The good thing about vision being motor and vision being a learned process is there are things we can do to treat and improve visual conditions. Some obviously are more easily treated than others, but there's a lot of things you can do for a large number of patients to at least improve the situation. And again, we have part of our motor-based vision model is we have a central peripheral visual systems. We actually have, and it's been shown on microscopic studies of brain tissue, we actually have two visual systems. We have our central and our peripheral. And again, when you're just measuring how well you see an eye chart far away, you're just measuring central, which is only about 6% of the retina. So most of the eye exams ignore the other 94% of the vision system. The peripheral is our where is it system, and our central is our what is it system. And we have M's and P's here because the neuroanatomy people have designated these as magno and parvo, large and small cellular systems. So you'll see that the very center of the retina is almost all parvo, almost all detail. And we have very little cells in the back for the peripheral because we're just using that central retina for clearness and acuity. Where the peripheral, again, balance, movement, navigation is that peripheral system. And that's where we see a lot of people really struggling. We see people coming in who have trouble walking, need to be assisted. I've had patients in wheelchairs with Lyme. I've had patients who are using canes and walkers and other navigation appliances to help them get through daily living. This I won't spend much time on. This is a visual field. We spend a lot of, we talked about the peripheral, but the peripheral vision can tell us a lot about where there is a problem with the brain, especially with our stroke and our traumatic brain injury patients. You can really zero in on what part of the brain is affected based on how you map out the peripheral vision. We'll show you, we'll show you a patient map in a little bit. But so we have sort of the top of the picture shows you the two eyeballs, and that's the front of the brain. And then as we move down, we move further to the back of the brain. And then we will not give you a quiz on bilateral heteronomous hemianopsias. Won't be a spelling test. And of course, then we have our action system. We have another two parallel systems. So you get this image come in through the eyes, goes through that optic nerve pathway that I just had up there, ends up in the back of the eye, which is the visual cortex, which processes visual information. Now the brain has to figure out what to do with it. And so we have our back to front movement of information. And you start at the back, the occipital, and then we go to the front is the frontal lobe. And we have our dorsal and our ventral systems. So you have one system that gives you detailed images and the other one that directs the movement. They've done studies on patients who've had trauma to one or the other, where a patient, maybe you show them a picture of a tissue box or a box with a slit in it, and they can tell you exactly what they're looking at, but they don't have the ability to guide their hands to direct, let's say, a flat sheet of cardboard into a slot. And they could have the opposite, where they can actually move it around, but they can't tell you what they're looking at. So again, there are these dual parallel systems that you could spend 3 hours just discussing them. But we have the neuro-optometry has a real dorsal based system. We're very much into direction of movement and action by the visual system. Let's get into the nitty gritty here. We'll talk about some basic visual skills, visual processing skills. Again, these go beyond just clarity of what you're looking at. So these are the chief ones. There's really about 20 different visual abilities. Number one on the list, because this is the one that occupies a lot of my chair time with patients, is convergence. Convergence is the ability to use the two eyes together as a team. We have eye movements. So you have to direct the eyes to where you want to look at, to what you want to look at. We have smooth eye movements, which are called pursuits. We have saccadic eye movements, where you jump from one place to another. So if you're watching the car next to you while driving, that's mostly a pursuit activity. But if you're trying to read a book, that's mostly a saccadic activity. We have to jump from word to word and line to line. There's other types. Fixation, just keeping the eye still, is considered a movement as well. Accommodation is the $64 term for eye focusing. The eye does have some similarities to a camera, and we have a lens that changes shape. And for most of us who do not have any injury or Lyme-related ailments, things just change, just get really clear really quickly until you're getting to your 40s, and then you start to have trouble with holding things far enough away. I'm wearing a bifocal lens because I do not focus as well as I did 10 or 15 years ago, and this helps me out quite a bit. And we use the term accommodation, I think just because they like to check how well we can spell things. No, there's a lot more to accommodation than just focusing, but we will concentrate on the focusing aspect of things. The ability to see clearly. So there's a whole cascade of information. We have to deal with gravity. We have to learn where up and down is, and we have to know where front to back is as we develop visual skills through the first 3 or 4 years of life. And we have to learn where things are. We have to identify things. We have to be able to match it up with what's in our language, so I could explain what I'm seeing to somebody else. And language is very useful in me relaying my space world to other people. And then lastly, we had peripheral vision. Again, 94% of our retinas are really peripheral vision. And constriction of the visual field is one of the more common issues with Lyme as well. So we do a lot of work to get people to restore their peripheral vision. What are the more common issues we see with within neuro-optometry and within this Lyme population? Convergence insufficiency, that's probably our most common diagnosis. That's, again, where you lose the ability to use the eyes as a team up close, be it for reading, writing, craft work, etc. Just eating a meal takes time to locate what you're looking at. And if you don't have enough, you have a convergence insufficiency. You could also have a convergence excess. That's where you converge your eyes too much. Both of these patients may have double vision, but for different reasons. And that's much rarer than convergent insufficiency. So these, I said, I put up my top 6. Accommodative insufficiency. Again, you're losing the ability to keep things clear. These patients run out of gas. They can read, but only for 10, 15, 20 minutes, and then they kind of develop a headache or fall asleep or just unable to read for a long time, or and they're pretty unhappy because they know they can do it. They just can't do it for very long. Strabismus is an eye turn. We see a lot of, for Lyme disease, we see a lot of paralyzed or partially paralyzed eye muscles. And these are patients, again, anytime we get a patient presenting at my office with a recent onset eye muscle palsy, I frequently request Lyme tests to be done because anything odd neurologically, we like to get a Lyme test done. And so if somebody has odd eye test, and it could be for different reasons. There are different reasons. Eyes that turn out frequently mean thyroid disease as well. Eyes that turn in can mean some other systemic problems are going on. So, we play detective when we get a patient coming in with Lyme-related ailments. We play detective and see what's working, what's not working, and what do we have to do to get this patient functioning visually as best they can. Next is something called visual midline shift syndrome. We have a concept of where straight ahead is, and I know where straight ahead is. I know where my left is, where my right is. A lot of patients that have neurological issues, their concept of where straight ahead is does not line up with where things are physically. We see this with Lyme patients. We see it a lot with our post-concussion patients and our post-stroke patients who frequently have no idea where straight ahead is. Other things we have here are a low blink rate, and that goes together with dry eye. We see a lot of patients that have neurological issues. They kind of have this interesting stare where they really don't blink too much. You're supposed to blink, 11, 12 times a minute, and it's like 2. And if your blink rate is low, and then you go work on a computer, which lowers your blink rate, you might get a double whammy here and have quite dry eyes and very uncomfortable, and it does degrade the clarity of your vision as well. And last one here, I put visual field, and there's functional and there's absolute visual field. Somebody that's had a stroke to the left hemisphere of the brain frequently loses their right hemisphere of vision on the opposite side. And but that's a pathway problem. Like, remember, I had that picture earlier on, like my 3rd or 4th slide. But we also have functional visual field loss, and very often their ability to use their peripheral really shrinks down. This is a stress response. It's a sort of a fight or flight, adrenaline, sympathetic nervous system issue. And stress causes, because the stress does a number of things to your body, and the body doesn't care where the stress comes from. It responds in the same way. It pumps out adrenaline. You get this whole cascade of events to fight or flee, fight or flight reflex. And then when you're done doing that, then you're supposed to relax and things return to normal. You replenish your stores of energy, your glucose levels. Get ready for the next time you have to do something. And so stress, one of the other things is the field shrinks down. I'll tell this, that most parents know exactly what this is like. when you're 20 minutes late and the dog is barking and the kids are screaming and phone is ringing and you can't find your car keys and they're right on the counter and you almost have to wait for your kid to hand you them. But because under that stress, you've really tunneled in and the ability for you to use your full field of vision is really becomes limited. So we spend a lot of time when we see these Lyme patients, if their fields are abnormal, we do a lot of work using something called Syntonics. I'll get to that later, but there's other ways too, to restore the full visual field. And it's amazing. And we have some patients who can't drive a car because they're so limited on their field. And we could just open up the field 5 or 10 degrees. It's like, wow, I'm not so nervous in the car anymore. I think I'm now starting to drive again. So visual field, again, 94% of your visual space is peripheral. So let's talk about what are the ocular manifestations of Lyme. I was hoping there would be a gazillion articles on this when I first did some lecturing on Lyme. And I found out that they were kind of limited to, though Lyme is getting more attention, I keep checking, but not a big topic in terms of vision and Lyme in the literature. So there was an article by Lesser on ocular manifestations of Lyme disease in the American Journal of Medicine, and Fitzgerald, who was actually one of my instructors in optometry school, wrote an article in 1990. So they do talk about the convergence problems and the other issues there. They tend to talk about more of the hardcore pathological issues, optic neuritis, which is swelling of the optic nerve, Bell's palsy, which if you're in the area we're living here in the Northeast, and I've heard this is a conservative number, if there's Bell's palsy, it's at least 25% of the cases in the capital region of New York are due to Lyme, which is really high. And eye tissue inflammation, uveitis, that's some of the deep tissues. We also have people will get conjunctivitis, which is just kind of a Lyme version, a form of pink eye. And we also see some unusual cranial nerve palsies. We have 12 cranial nerves. They go to different parts, usually from the neck up, controlling various functions. We have 6 of the 12 cranial nerves. 6 of them have something to do with vision. So they control those muscles that you use. If one muscle is not doing what it's supposed to, we have this nicely balanced system where all these muscles have opposing muscles to keep you balanced. If you want to look left, you do one set of muscles. You want to look right, you do a corresponding opposite set of eye muscles. And if you have a problem with, let's say, cranial nerve number 6 goes to just a single muscle on the temporal part of the eye, and it helps your eye look outward. So if that nerve is not working right, that eye is going to turn inward. And we do a lot of work, again, to restore muscle function on patients like this. We'll talk about how. So somebody wrote this article. This was getting into some more recent articles. Lyme disease and convergence insufficiency, is it a near fit? And they did a retrospective study. They took a large number of patients and went through to see how many were diagnosed with convergence insufficiency, and found out it was 53% of them, so more than half of Lyme patients had confirmed cases of convergence insufficiency. We just call it CI. Everything now has to be an initial now. Watch commercials on TV at night for various meds. They don't tell you what the disease is. They tell you the initials. Half the time, I have no idea what they're selling me. But I saw one last night for DED, which is dry eye disease. And I knew what that is, but I said the average person at home may not know what DED is. So, but they know they should ask their doctor for it. Anyway, the good thing about convergence insufficiency is we do handle it pretty well. A lot of the population, 15% of the population has convergence insufficiency just due to developmental issues or just inefficient convergence system. And they respond really well to optometric vision therapy or neuro-optometric rehabilitation. We probably have like a 98% success rate on that population. I will say our population, our success rate with the Lyme population is going to be much tougher. They tend not to respond as well as the more common type. And again, just the more complex disease that we're still learning a lot about. But we still put them through vision therapy for the most part, and can definitely improve symptoms quite a bit. And with the combination of some of the other things we do. We don't always do just vision therapy by itself. What kind of symptoms does the neuro-optometric patient have? Do we see with Lyme? We talk about blurred vision, may have double vision, two things where there should be one. Again, if you have an eye muscle that's offline because of a muscle palsy, you very much will end up with double vision. And these patients frequently come in wearing a patch from their previous eye doctor. About half the time, they wear the patch around their neck because they'd much rather, the patch limits their peripheral vision, which really messes them up. So many patients would rather have double vision and just close an eye when they need to function. Headaches, very, very common. They run the full gamut from mild discomfort to full-blown migraine type headaches. So we see a large number of that. Reading problems, the ability, well, again, if you have a problem with convergence or with, oops, somebody just checked in, with convergence or focusing or tracking, I asked them, are they having trouble with the print? Are they having trouble with comprehension? Again, a lot of these people, they just can't read. It's just too uncomfortable for them to read because their convergence ability is so compromised. And I see a lot of balance and vertigo patients. This is a hot topic. There's a doctor, he's a friend of mine, Dr. Kurt Backstrom in Seattle. And he's the guru of vertigo. And he teaches all of us how to deal with vertigo in different ways. But we see a lot of people have vertigo while driving. That's a common thing. We get a lot of people who are like afraid to drive because of their symptoms of vertigo. They may have postural changes. We'll talk about why in a couple of minutes, but you see a lot of different postural adaptations to the system. And here we keep coming back to constricted visual fields. Again, there may be spots they may have lost in many strokes. On a worst case scenario, you may lose 50% of your vision right down the middle. You might lose everything to the right or everything to the left. And again, mapping out the field tells you what's going to happen. If they have a right field loss, they probably have a problem with the left part of the brain and may end up with some aphasia or word finding problems, language issues. If they have a visual field loss on the left side, They may have something called visual neglect, where they're not aware that they're missing vision off to the left side, where the people on the other side are aware. They'll tell me, oh, yeah, Dr. Fox, I could see half your face. Whereas those who have that left visual field, if that left space just doesn't exist. If somebody could walk in the room and say hi and sit down on the left of a patient, and you go, can you point to Johnny now? And they'll say, oh, Johnny's not here anymore. Or they don't eat the food on the left half of their plate, things like that. Very often we get this kind of bull in a china shop. Due to missing or constricted visual field, they bump into things, they trip over things, they walk through doorways, they keep hitting the edge of the doorway. So lots and lots of issues there. This is just to show you what happens when we converge our eyes. So when you're looking far away, your eyes are basically parallel to each other. And when you want to look at something far, you need to converge them just a little bit, something that may be 8 or 10 feet away. You have to do a little bit of convergence. But to read, you may have to converge a lot. Okay? And you must move those eyes inward and maintain clear, comfortable, single vision to be able to read and use your eyes up close. So, what happens to print when you're not converging well? This is something out of Disney, and we'll have a couple of comments about this, but this is somebody who is converging and focusing well. The print looks clear, the print looks single, nice and crisp, easy to read, easy to recognize words, easy to see word early and recognize it later as the same word. Whereas if you're not converging, even just a little bit off, look what happens to the print here. It really gets messed up. And this is off by just a matter of a couple of millimeters off. So which way would you rather read something, this way or this way? Or what happens more often than not is you try to read and this is what you're reading with and you just don't. Or you just get a headache within 5 minutes and you're done. So this is where one thing that does help is magnification. Notice the print up high is easier to see than the smaller print. Okay, so magnification can be useful. I really do like Kindles because you can adjust the font size on things and you can read a little more comfortably with that, as well as adjusting the lighting and the contrast. And again, convergence insufficiency, again, the most common of the conditions we see is rising from Lyme and other neuronal insults. Symptoms can vary greatly from just vague discomfort to blurred vision, headaches, double vision, and reading problems. And it's frequently missed in routine eye exams. So I will say that only I don't want to know this percentage. I hang out with people who test for convergence insufficiencies frequently, but I would say probably more than half the eye doctors out there do not. So they would tell you, your eyes are healthy, you see 20/20, you don't need glasses, you're having lots of headaches, why don't you go see your neurologist or some other specialty. I put this on the bottom here. This was not my term. This was from an ophthalmologist who worked together with an optometrist and had a lot of referrals back and forth. And they said the undiagnosed convergence insufficiency is the most common cause of the walletectomy. The walletectomy means unnecessary and expensive medical tests. And I think it's a great term. And, I've had patients come in and we've prescribed glasses and we've cured the headaches, and they've been to 3 or 4 eye doctors before they've come and seen me. And I explain, usually when I'm about 5 minutes into the examination, and they go, wow, that's the most thorough eye exam I've ever had. And I'm just like 10% into my exam. So a lot of the emphasis on eye exams is on eye health. A lot of my colleagues, if they have a patient with unusual headaches, they'll send them for an MRI, and which will almost always come back negative. And again, they're put on various types of painkillers to treat symptoms. And we rely on other referrals for them to come to see us and get themselves treated. So it's common. A lot of these symptoms are very, very vague. Oh, I think I find people just say, I don't lost my interest in reading. I just don't read anymore. I feel clumsy, or I don't drive. I get anxiety when I drive. So we have all these things that come back to the undiagnosed convergence insufficiency. Accommodation, we talked a little bit about focusing on our intro here. Most of the time, you can't go by age. A lot of doctors go strictly by age in prescribing glasses for reading. The average person, usually about 40 to 45, talked about their arms getting too short. I got to get this here, too short, and you need to hold the print away to read. And most doctors won't even, I've had patients having trouble because they're just farsighted, or they're getting an early accommodation problems. They're 37, 38. I mean, 40 is an average. That means half get it younger. And some doctors, it's like a religion. I won't give you reading glasses if you're under 40, or they won't prescribe reading glasses that somebody desperately needs because they have Lyme and they now focus like a 65-year-old instead of like a 40-year-old. And most doctors don't even measure focusing. They just, again, go by the age. And as you get older, you need stronger reading lenses. And these patients kind of suffer, and they've gone to the eye doctor. They've been checked. They're told there's not a problem. And some of them end up self-treating with magnifiers at the drugstore if their prescription fits in. But very often they're just told they don't need glasses yet. So, and again, symptoms can be mild, symptoms can be severe. Blurred vision, reading problems, eye fatigue. Again, people with focusing problems, they just don't have much visual stamina. And they do so well with lenses. It's really rewarding to just get some reading lenses on some patients. I've had patients, I'm putting on my trial lenses, and these big ugly metal things. I put their prescription in and give them something to read. And as they're walking out of the office, though, oh, I was hoping I could take those trial frames with me, because now I can read again. I go, no, I gotta keep that in my office for the next patient. But lenses work really well on cases of focusing dysfunction. Eye movement disorders, okay? So we have fixation, that's aiming the eyes. We talked a little bit about this. Pursuit, moving the eyes smoothly from one place to another. Saccadic, jumping the eye from one place to another. I put nystagmus here. Nystagmus is an odd visual eye movement. It's where the eyes never stay still. They kind of vibrate back and forth, just a couple degrees. It can be a slow, usually it's fast in one direction and slow in the other. And it's very, very uncomfortable. And I have seen patients with Lyme develop nystagmus. It's a rare side effect, but I have seen it. And these patients are really miserable. They're They got their they got their hands over their eyes. They're really miserable, or they have some. I've seen patients wear dark sunglasses indoors just to try to lower the light and lower the stimulation. But people who have acquired nystagmus, the whole world looks like it moves around on them. Whereas congenital, the kind people are born with, the brain kind of figures it out how to see only when the eye is still at the end of each movement, and figures out how to survive and do well. Somebody's knocking at my door. Yes. Okay. I'll be there when I can. Okay, why do we go? We go till about 2:45?
Yeah, 3:15.
Okay. I may have to tell somebody something, but I think somebody didn't realize I was still talking.
Okay.
Problem with closing my door. Anyway, people who are born with nystagmus, they figure it out. We have worked with some patients with nystagmus and just teaching them how to slow it down and do better. Because the faster it is, the poorer you see. And let's see. And some we help more than others. I've seen people even have side effects on medications that cause nystagmus. So very uncomfortable. Peripheral vision. So again, stroke patients can lose a quarter, can lose a half. You may have some blind spots. We call those scotomas, where you may have blind areas of vision. Very uncomfortable if they're near the center of your vision, let's say 5 degrees off from the center, but a little to the right. We read left to right. So you might have trouble seeing the ends of words. If you have a blind spot to the left, you might have trouble finding the beginning of the next line when you read. Once upon a time that we did not have many tools to deal with a peripheral vision loss, but we actually have quite a few now in terms of lenses, prisms, and optometric phototherapy. So, and we also talked about visual midline shift. Again, the patient just loses their ability to know where straight ahead is. It could be left, right, it could be up or down. And what happens when you have a shift is your whole world around you gets shifted too. So you feel like you're getting pushed to the left, so you push back to the right. And that becomes your normal posture, and you really fall off place, and you can't walk. These patients can't go down a supermarket aisle. They drift all the way to the side, or they snake back and forth. So supermarket aisles are also really overly stimulating. It's like a repetitive pattern of cans on the wall there, or cereals and things. And it's very overstimulating for our Lyme patients. So, and also we got patients who have trouble walking because they either fall forward or fall backwards. So again, their concept of knowing where the horizon is all messed up, and it can be very dangerous. A lot of these patients are wheelchair bound because every time they stand up, they just fall right back. So very, very difficult to deal with. So we'll now talk about what do we do about these things. And so what's in our neuro-optometric toolbox? Number one, lenses. Lenses are really, really powerful. Even small powered lenses, half or a quarter of what people would normally prescribe, are often really, really powerful. I've seen patients who are really hunched over and get the right lens on them, and now they stand up tall, or they tell me now the floor looks straight again. So lens is really powerful. Lenses godsend for somebody that has a focusing problem and needs reading glasses, even though they're in their 20s. I don't care how old or young they are, but if I can help them read again because they're post-Lyme and no longer focus well, I'm not looking at their age to keep me from doing that. I'm going to prescribe that lens. So prisms, because we're going to go through these more in detail in a minute. So I will talk about prisms. We'll talk about selective occlusion. We'll talk about syntonic or phototherapy. And we'll also talk about neuro-optometric or optometric vision therapy. So lenses, these are often for comfort and stress reduction and performance. They're not for acuity. In fact, sometimes I intentionally prescribe a lens that's a little weaker than the full amount because it helps them with their balance. That giving them the full prescription doesn't necessarily help them with their periphery. Often reducing the prescription by a quarter or half of a unit puts a little less emphasis on the central, a little more emphasis on the peripheral. Small powers can have large effects. I will sometimes prescribe a weak lens for a Lyme patient. I get a call from the optical place they go to, and they say, "Are you sure you want to do this, Dr. Fox? This is like hardly any prescription in there." And I'll say, "Thank you for calling me. Really appreciate it. This patient has a vision condition that is best treated with these very weak lenses. Thank you for checking up." Because I've had some places try to correct my prescription and say, "Dr. Fox must have meant something larger." And sometimes the smaller lens has the bigger effect, especially in balance. We try to avoid no-line bifocals. They have a lot of distortions built into them. They also have prism built into them. And they may have optical qualities that the Lyme patient cannot tolerate. And we often find they do better, especially if they have balance and vertigo issues. They do better with a separate pair of reading glasses and a separate pair of walking or distance glasses. People who spend a lot of time on computers, again, we live in an age where we're all spending time on computers and doing lots of close work. And again, you might need a specialty lens just to help you get through the work day, or if you're a student through the school day. And you want the right equipment for the job. You know, you won't wear soccer cleats to play baseball. You wouldn't run a marathon with baseball cleats, so baseball shoes. So we tell people, you're on a computer, you need a specific prescription. We may give you different types of tints, either blue blockers or anti-glare or various other types of, there's so much stuff out there now to improve comfort. So we do a lot of lenses, but we also do a lot of tints as well. Blue tints, rose tints are the most common, but we may use amber tints for some patients, or maybe use some blue blockers for some patients as well. So right now, the early research is coming back very iffy on the blue blockers. It's kind of 50-50 whether it helps you or not. And you don't know until you actually try it. So hopefully some better research will come out soon, because when they first came out during the pandemic, everybody was saying, well, you're on the computer, you must wear the blue blocker. And now it's like, maybe we can try a blue blocker and we'll see how it goes. So lenses are cool. There were several lectures on lenses and posture at my conference last week. Dr. Samantha Slotnick in White Plains is doing some really cool stuff. We're going to institute some things here. Prisms. So what's a prism? A prism is, you may remember those pictures of white light going through a prism. It comes out as a rainbow. Prisms bend light without changing the prescription. So they can move where the light's coming from, up, down, left, or right, and change where you perceive it. We use them for visual midline shifts. And to get that midline lined up with where your physical midline is. You can also use it to help with visual field loss. So somebody who has visual field missing to the right, you want to prescribe a lens that shifts light to the left or the right. Again, it depends on the patient. So, and the specific area of the brain that's affected. We can restore balance to a depleted system. We can expand or compress space. So we see that a lot with those visual midline shift patients. Their whole world to one side is compressed, almost like looking through the wrong side of binoculars, and everything kind of gets shrunken down and squeezed in there. And using lenses, especially prisms, we can expand that space and get them to be balanced and get them to not tilt over one side or the other. Prisms also can help you with fusion. So a lot of our convergence insufficiency patients do very well with small amounts of prism to just reduce. Optically, it moves the image further away, so you don't have to converge quite as much. So instead of converging 10 degrees, maybe now with prisms, you only have to converge 5 degrees. And that's much easier in terms of comfort, balance, and fatigue levels. And we also, some of the double vision patients who have an eye that's going up, down, left, or right, again, we can line up the images using prisms to restore single vision. So we have a lot of tools at our beck and call for those double vision patients. Many of us really try to avoid patching. And like I said, a lot of the patients will tell you they hate patching. So something that's making a lot of press these days is mainly because of some TikTok videos. It's amazing. The power of TikTok just blows me away. These things can spread like wildfire. And this guy did a video on something called binocular vision disorder or dysfunction, which is where the eyes usually have a little bit of what we call a micro strabismus or a micro turn, where one eye is just a half or 3/4 of a degree higher than the other eye. And conventional, you need special means of testing and prescribing because most of our tests don't measure that small an amount of prism. So there's a couple of companies out there selling different prismatic systems, and I don't want to promote one or the other here. And but they have discovered that you need to, and very often if nothing's working in terms of lenses or prisms, you need to start looking for just very, very small amounts of vertical and or horizontal prism. And often, can improve things greatly. Some of those patients improved 70, 80% in terms of symptoms, and they're very, very happy. We've had some patients tell us they drove a car for the first time in a couple of years after they got their prismatic lenses. So you don't know, it doesn't work for everybody, but when it works, it's pretty cool. I've had some patients throw away their canes. Wish I could predict which of my patients will always do that, but I've seen patients do it. It's really cool, and they tell me the lenses, the prism lenses, are miraculous for them. This is just showing you on the bottom how light gets bent towards the base, the fat part of the prism. You have your base and your apex, base the bottom here, apex the top. The light looks like it gets bent towards the base, but that means where you think it's coming from gets bent towards the top or the apex. So it sounds backwards. I don't want to get into an optics course here. It took me long enough to figure out how to, actually I was pretty good at this because I have an engineering degree. Used to tutor optics. But you have, plus lenses are thicker in the middle than the edge, and minus lenses are thicker in the edge than the middle. And they all have a prismatic effect to them, sometimes by intention. So let's see what somebody does who needs some prism.
Okay, why don't you walk forward towards me?
Okay.
Stop. Good. And walk backwards back to where you came from.
Oops, sorry.
Okay.
Is that all better? I don't
Okay,
have
good. Stop. Good. Okay.
that.
So she had a problem. She had actually, I think she had a mild stroke, a young patient. And you could see her balance is all messed up. And then we put some prisms on her.
Okay, this is with prisms on. Walk up to me. Stop. Good. And walk backwards.
So very different here. Our ability to walk forwards and backwards, long strides, not falling off to the side. And she did very well. So we prescribed glasses that had a little bit of prism here. I tried a lot of other lenses. Didn't get it right on the first one. I have my box of lenses and prisms here. This was at a rehab center. And we're able to help her quite a bit. Selective occlusion is different from patching. It provides central lock while allowing for peripheral awareness. So again, we're trying to get more awareness of the periphery. It reduces confusion. So some of our patients, we have trouble getting rid of double vision. We can help make double vision less noticeable. And with selective occlusion, occlusion is patching. So we maybe patch just a small portion of the lens. I'll show you in the next slide. And helps filter out visual noise. So again, patients who have neurological issues like Lyme, concussion, stroke, they don't filter well. They have trouble with figure ground, and we could help them with lenses and selective occlusions. Also helps with midline, also helps make double vision less noticeable. Here's what binasal or nasal occlusion looks like. I usually don't go much wider than this. Sometimes you have to, but usually you don't need to go very wide. And in fact, sometimes I've gone much narrower than this. I have a bunch of patients who I literally have 2 or 3 millimeters of tape on their lenses. I had to get a special like nonstick scissors so I could cut out the sector, the tape. So what's nice is it's something to try before you go to order a lens. If I could reduce symptoms and make them feel happy with some Scotch tape on their glass, and this is just regular Scotch frosted tape. You know, glasses are great, but glasses have gotten expensive for people. If you need a bifocal lens, and she looks like she's wearing a bifocal here, yeah, that could be $700. But if I could relieve symptoms the similar amount by putting a little bit of tape on the lenses, I think that's a win for me and the patient. So, but it really helps make things much less noticeable than they were before. And it's so easy and simple to try on most patients, like most Lyme patients with vision issues, easy to try. Syntonics is optometric phototherapy. It restores balance to the autonomic nervous system. That's again, we talked about fight or flight, have our fight or flight, sympathetic energy out there, parasympathetic, rest and regenerate. Think of it as a seesaw. And if you're amped up on one side, that's not healthy. If you're amped up on the other side, that's not good either. So we try to pick a filter, and it's light, that somebody who looks at a different instrument that I have out there. We have the instrument, we'll show you one. They look through this tube, we put different filters in, and over the course of 3 to 5 weeks, if we've picked the filter correctly, the field should open up. Sometimes on a recent injury, there may be actual inflammation in the neural system. Sometimes it just acts like there is, because it's just under so much stress. And again, headache, pain relief. It's very gentle and very few side effects. So, and it used to be you had to come into the office to do it. Now we do a lot of home therapy with some various home instruments and goggles. It's a very hot topic. I actually help teach people how to do this. I help teach the introductory course, and we get calls all the time. I had a call today from a doctor not far from here who wants to know when our next course is. I think she's ready to make the jump. So, and light therapy can be done as a standalone therapy or as a adjunct to other therapies you're doing for, let's say, the convergence insufficiency. And you can see the upper left is a small field. This field is less than, those dots are 5 degrees out. So this is like a 3 or 4 degree field. We do different colors. So I have white and blue, and sometimes I'll do green also. And this is after a month of therapy, of light therapy. The field is now opened up 5, 10, 12, 14 degrees. And then another few weeks later, and the field is about 20 degrees, which is a good place to be. So look at the difference. Who's going to have an easier time driving a car or a navigator or having balance or reading a book? The person who's looking through a straw or the person who sees the whole field? So hot topic, hot topic. And this is just showing that seesaw. We have the left side is the red end. That's more sympathetic fight or flight energy utilization. The right side is the blue or violet end. That's calm, relaxation, healing, anti-inflammatory. It's almost like an ice pack for the eyes. Very, very powerful. I've had some patients in a single treatment tell me their headaches get better. This is one of the older style syntonizers. Again, you put your head in the tube here. You put the filters in slots here. There's a light switch. There's a special bulb in here. We've all had to reinvent some of these equipment because they don't make incandescent bulbs anymore, or they're very few and hard to get. So we've had to use different light sources. And then we have neuro-optometric rehabilitation, retraining of basic visual abilities. So we can learn how to converge. We can learn how to track. We can learn how to focus. And again, we're training the brain, not the eye. We have to get them to understand where center is. We'll do a lot of activities. We'll have them bunt balls. We'll have them touch things at midline. We'll have them work at crossing midline. Help reestablish the sense of center. We do a ton of work like the light therapy and prisms and lenses to improve peripheral vision processing ability. And of course, we want to do everything we can to have clear, single, comfortable vision, which may include lenses, prisms, tints, and light therapy. And vision is meant to lead. We want to make sure they're using the eyes to lead what they're doing motorically. So this is just, I just moved my office 2 months ago. This is my old office. I got to take pictures of my current office. But we have, it looks like anybody that's ever had any OT or PT, it kind of looks like a PT gym. We have walking rails, we have trampolines, we have balance boards, and we try to keep it fun. And we have a separate room in the back for the patient who needs a quieter space and where it's just too busy, like after 2, 3, 4 o'clock is after school time. We got a lot of our pediatric cases, and the place can be hopping. Might not be a good environment for a post-Lyme or post-stroke patient. So is Jeannie. So we do a lot of adults. So once upon a time, my practice was like 80 or 90% kids. I'd have days go by where I only do kids. And now, thanks to the growth of neuro-optometry and the demand for it, I'm almost 50-50. Not quite. I'm probably like 60-40, still kids. But we have a lot more vision therapy patients. So I'm teaching Jeannie how to do that smooth pursuit eye movement. I tried just having her look at a thumb or hold a shiny object, and she said the background was too overwhelming. So I took something, I went to the dollar store and I bought a splatter cover and put a little letter in the middle of it. And she was able to now do eye movements and retrain herself how to do saccadic, pursuit eye movements, smooth eye movements. So yeah, love the dollar store. I got a lot of stuff at the dollar store, including my Scotch tape. This is somebody learning how to do eye-hand coordination. This is a pegboard. We give them golf tees, and as this disc is spinning, the patient has to put them in, but not hit the edge of the board. It has to be in the center of the circle, so they get that accuracy here. And we start very slow, and some of our adults and Lyme and stroke patients, we really can't spin it. It's just too much. So you got to know how to ramp it up and how to dial it back. There's something called the Brock string, which is dangerous because it looks simple and it looks easy. So we have a lot of OTs and PTs not checking with the doctor before doing it, because if you have an eye that's already turning in a little bit, you might turn it into an eye that's turning in all the time if you don't get the diagnosis from an eye doctor to know what to do. So, because you don't know how to measure the eyes drifting in or out, and we're here to help you. And we want to empower therapists to be great therapists and work with these patients. But you got to get the right prescription, you got to get the right prisms, you got to get the right tints, you got to get what's best for this patient, and then you could start looking at therapy and talk to the doctor about where does he recommend you should work on. So I'm going to wrap this up and then take some questions. So neurological implications are Lyme. There's a good chance, again, the statistics and the research say more than likely than not, there's some type of convergence focusing tracking problem, convergence being the largest. But you lump those all together, it's a lot of patients. Convergence insufficiency, most common diagnosis in these patients, but not the only one. Neuro-optometric services can help improve patients' comfort and reduce symptoms for many with Lyme. And again, there's many that we just improve things, but we'll take what we can. And sometimes they come back and we've got some new stuff to try. You never know. So we're trying to improve quality of life and comfort and allow them to go back to doing things that they did before. And the toolbox keeps getting bigger. So sources of information, the Optometric Vision Development and Rehab Association, OBDRA, that's the meeting I went to last week. Optometric Extension Program, also known as OEP. And then there's the Neuro-optometric Rehab Association. That's an interdisciplinary group. So if there's any OTs or PTs out there that are looking for a conference to get some training and coursework in rehab end of things, with the visual rehab, they run a really good meeting. Usually it's in the fall, September, October. It's very multidisciplinary. I'd say half their members are actually not optometrists. They're OTs and PTs and other people who work with this population. I think I'm lecturing there next year too. So, okay. Thank you. This is my contact information. That's my office number. Fox Vision Development. Oh, put spaces in between. Oops. Fox Vision Development, no spaces.com. And info@foxvisiondevelopment.com is where you could leave a message and we'll call you back as soon as we can. So that's what we got.
We
Okay.
will have copies of this to share with people who came today, and also all the contact information you gave us.
Okay. I stopped the share. Okay.
Okay, great.
Any questions? Who wants to? I guess, Maria, you're moderating.
We have some questions lined up in the chat.
Ah,
Okay, first question, or first set of questions. How many syntonic sessions do patients usually need?
the average series is about 20 sessions. Okay. We mostly are doing it at home, and we'll have them do it 5 days a week for a month, and then frequently take a month or two off and then do it again. So,
Next question. When would you use eye muscle surgery instead of visual training for, I'm going to butcher this, diplopia?
uh-huh. Well, yeah, diplopia is double vision, and we try to avoid um, eye muscle surgery because the results are unpredictable. Statistics range from about, usually comes out to about 40% success rate. We will usually do it, if all else fails, you can't undo the surgery. So we like to do surgery last after we try the eye therapy. Often, if there is a very big vertical or just a real big bilateral inward eye turn, we will talk to a surgeon about doing surgery. We may do some therapy just to get better movement of the eye muscles, just to try to stack the odds of success of the surgical procedure. So we do have recommended it, and some cases have turned out better than others. It's variable.
What are some home syntonic machines?
Well, there's two ways of doing home syntonics, and again, you got to speak to your doctor because they have to prescribe the filter. There's 13 different filters, and then combination of them, so you can't just pick a filter. But there's two. One looks almost like a little table accent light that you might put on a table or light up a picture on a wall with, and it has different filters that you slide in. There's like three or four different companies that are making those. The other one that people are doing just because it's cheaper and easier to get started before buying lots of equipment is syntonic goggles, where they're like disposable goggles with filters in them, and it's a very, again, it's more cost effective. However, it often takes longer to get the results. Instead of 20 treatments, you might need 40 treatments to get to where you want to go. So, but it is available for people who, for some reason, don't want to or cannot use the rented light units.
Next question. How do small lens powers help with balance?
Small lens powers, there's something, well, I'll give one example. We have something called the VOR, or the vestibular ocular reflex. So when I turn my head 10 degrees to the right, my eyes go 10 degrees to the left to stay on what I'm looking at. And that's to help me stay balanced as I move through space. You can change that relationship if it's not exactly a 1-to-1, if it's not 10 and 10, but it's 10 and 5, let's say. You might be able to get them more equal by putting a low-powered lens in front of the eyes. And that gets you back to that 1-to-1 ratio of vestibular ocular reflex. So So that's the main reason. Also, there's a lot of studies that say the weaker powers seem to stimulate more peripheral retina, whereas the stronger powers stimulate more central retina. So that's another model out there of why the small powers work well.
Oh, I think you addressed this, but maybe you can go into a little bit more detail. Why do you avoid no line bifocals?
Number one, they mostly have prism ground into them. That's a problem. So they come with prism unless you specifically ask them not to. There's a lot of distortions. The clear vision is really just in the center of the lens. I'll get in front of my camera. The center of the lens has that power that you want. The periphery, the left part and the right part of the lens has distortions. And if anybody remembers when they first got their progressive or no line bifocals, the first 2 or 3 days were a little bit weird. Everything was a little curved and moving, and then you adapted to it. These neuro patients just don't seem to adapt to it, and they're just unable to tolerate the distortions. Really,
that's me.
Yeah,
I couldn't tolerate
you
either
couldn't tolerate it.
bifocals.
So imagine being that way all the time. That's what it's like to be a neuro patient. Yeah, not for everybody.
Here is question about costs, and part of the question is this doesn't address progression correction. What is the cost of exam and average cost of lenses? And then there was a recommendation to a different provider in Connecticut who charged $3,300 for the exam and the lenses.
Yeah, I can guess who that is. So
Yeah, I'm not gonna repeat it.
I don't have to repeat
We
it.
have to raise our prices.
Yeah, yeah.
And there was an
As you should.
additional
You guys can get
question
into-
about do you take insurance and Medicare?
The only insurance we take is no fault for injury cases. The rest is self-pay.
Okay.
We'll do everything we can to help you. April helps a lot of people that I previously didn't think could get to pay for. But I just want to say the range of the fee can be from $200 to obviously a couple of $1,000. Glasses vary from place to place. Glasses can be as little as $200 or $300, but the glasses can also be $1,000 as well.
So the patient can choose where they have their glasses.
The patient is definitely free to go where they want. That they do go, if they don't go to their doctor's office, they need to then go back to their doctor and verify that the lenses were made correctly. Because some places don't handle prism well, especially small amounts of prism. So.
The other thing I can add about that for the lenses, if you come and you have them here, if there is a lens change within the first year, we don't recharge you for the lenses. If there's adjustments and things like that. So that's just one thing of getting them, from someplace like this instead of that, there's different warranties, different guarantees, and all of that too. And I also put my email address in the chat. So if anybody wants to discuss anything about cost or how to do things, with insurance, happy to answer anything I can as well.
Did someone have a question? We can't hear you.
I can't hear it.
Brenna, is that you?
Everything. Certified.
Can you hear me?
Okay, now we can hear you.
Oh, I didn't mean for you to hear me. Sorry. You know,
Oh,
I had the questions about Medicare and the cost of the evaluation. The evaluation is around 200. Is that correct? Or goes up to 1,000 for the evaluation?
it depends on what your needs are. But the starting point he was saying was 200. You can also call April
Yes.
at Fox Vision, and she can give you a better idea.
Super. Thank you so much, everybody, for coming today and arranging this.
Thank you. Great questions. One more question.
I have to
Uh,
mute my. Sorry. I don't know how to.
okay, thanks, Brenna.
Yeah.
What is the success rate to treat CI and Lyme patients with visual exercises?
I think our success rate with CI and Lyme is probably about 80%. Non-Lyme CI, it's more like 95%, but doggone it, that Lyme is tough. And I think if I'm doing 80%, I think I'm doing well. Lots of those cases, I'm just trying to get them to feel more comfortable and not necessarily cure their convergence problem. So I may use some prisms to try to just mask some of their symptoms. I'll do a lot of tints to just make things feel better. I mean, I get some of these patients coming in with 2 pairs of sunglasses and a hat with a brim and a hoodie, and they're just so light sensitive that if I could just reduce their light sensitivity, they could rejoin the modern world again. So, I'm not going to brag about. I think 80% is good, and at least 80% we've been able to help feel better than when they started.
Having a practitioner who recognizes that it is a problem and that's what's causing the visual issues is just amazing.
Yeah.
Final questions. Anyone?
A lot of good info on the NORA, Neuro-optometric Rehab Association. Has a lot of stuff about neural issues and treatment in general. It's a good website.
I want to thank everyone for coming today. Dr. Fox, this was an amazing presentation. I learned a lot. We will have the recording up of this on our YouTube page and the additional resources and how to contact Fox Vision.
And we'll try to get you a PDF or handout file. Okay.
Thank you so much.
Thank you. It was great.
Really appreciate your
Really enjoyed it.
time today.